Welcome to Ethics Lesson 5. We're going to be talking about economics, funds, and fictions. So, in this lesson, we're going to talk about insurance, diagnostic subterfuge, family, overtreating and undertreating, and when profit is king. Alcoholism is among the most common serious illnesses in the US, and it's the most common being heart disease. So if we combine alcoholism with the other chemical dependencies, the numbers are going to be even greater. It seems logical that the most common ailments would routinely be given a proportionate amount of attention in healthcare teaching, and that hospitals and health insurers would have worked out the most efficient and reasonable and effective ways of dealing with them by now. This, however, has really not been the case. A legacy of the Prohibition era is the moralistic posture that these are self-inflicted illnesses and symptoms of weakness, if not outright badness. It's seen as a sin or a social problem, then chemical dependency seems not to be the legitimate responsibility of the healthcare system. The use of street drugs, it carries with it the additional tarnish of illegality and the less visible problem of prescription drugs. Enormous though it is, it's failed to rouse a lot of public interest or concern. But then we have the 1960s, and it wasn't unusual to find hospital rules that spelled out that alcoholics were not to be admitted. And the physician who openly insisted on doing so was risking losing their hospital privileges. And then, when the laws changed and the hospitals were ordered not to discriminate against alcoholics, insurance coverage, was lagging far behind. So, of course, alcoholics got admitted anyways, but not only were they, uh, they're out there somewhere comfortable drying out spas for the wealthy, but the hospitals too found room for the affluent, the interesting, the privileged, chemically dependent person. Most could and did pay their own way since little insurance coverage was available, and treatment was often limited to brief periods of detoxification. We move into, the 1970s. Over those years, patients were frequently admitted, as they always had been, but not with a primary diagnosis of alcoholism or some other addiction, but usually under some sort of other label that would be socially acceptable and, more to the point, reimbursable by health insurance. And in many cases, there was more than one honest choice of diagnosis. If the patient suffered from cirrhosis of the liver and gastroenteritis, a bleeding problem, severe anxiety, organic brain syndrome, or depression, any of these would be presented as the primary problem, and treatment costs were then paid. Other patients tend to show fewer physical problems, and the physician often had to kind of exaggerate the complications to guarantee payment. So, in other cases, these complications had to be invented. Uh, what to call the problem really just varied with the hospital or the type of facility that was eligible for the reimbursement. If this system worked and and there were ways that were found to cover both the patient's and the hospital's expenses without unreasonably penalizing somebody who had contracted an unpopular illness, why was this so bad? Well, there are several reasons why. Such a system it discourages the design of specialized services for chemically dependent patients because it's hard to set aside beds for a condition that doesn't officially exist. And when one considers the poor insurance coverage for alcoholism today, the situation is even more frustrating since alcoholism treatment has become more competent and more effective. Inappropriate insurance patterns also create an unfortunate doctor patient relationship. Either the physician tells the truth and the insurance company denies the coverage, or the doctor conceals the truth and colludes in defrauding the insurance system. kind and lofty though the motives may be, the resulting behavior is just not honest. So when a physician lies about a diagnosis, be it to guarantee payment or spare the patient's reputation or permit the hospital admission in the first place, something else is happening. The physician is now being established as a liar. And it's important that patients be able to believe their therapists, particularly when they're asked to believe, or what we're being asked to believe contains a great deal of what the client would prefer not to hear. And then, after a dishonest beginning, how does the therapist go on to convince the evasive and denying and mistrustful alcoholic of the need for candor and openness and explain the honesty part of the 12-step programs? Many people see that regulations are too often unreasonable and the rules don't make sense. Some people feel that working the system in whatever way is necessary to help a patient, and it might be kind of like a justifiable form of civil disobedience. The goal is to heal the sick and make people well, but people who feel the need for accurate information object to that. They point out that if all the people who die of alcoholism are reported as having died of heart disease instead, the true impact of chemical dependency has been hidden. We can't protect the memory of the dead by concealing the facts and then bemoan our lack of data. Hiding both treatment and death behind an inaccurate diagnosis, it just deprives us of that statistical evidence that might help demonstrate a need for policy changes. And without this evidence, the task of developing more rational systems is going to be slowed. Treatment has increasingly become reimbursable without the subterfuge, but many problems still remain. As the needs of the family are recognized and as more professionals become convinced that family programs play an important part in both the patient's and the family's recovery, many programs have been designed. Residential programs offer an intense short term experience of less than a week that consists of just this basic education and some therapy. Family members live together in a controlled setting, which can help them to learn from each other and free them from the distractions of the home and their jobs. And these family programs, they offer space and a little time for significant others to examine the behaviors that they've developed in response to kind of like living in the insane ambiance of active addiction. Some insurance companies still have reservations about treating seriously ill addicts, specifically for addiction rather than for its late physical manifestations or simple detox. How then are they to regard a demand that treatment also be provided to the family member who has the illness once removed? If a man married an alcoholic just last week, is he then in need of treatment? Drug dependency is a family illness in a very real sense, but does that mean that every family member is sick and that the overburdened taxpayer or the premium payer should assume the cost of care? Does this mean that every mental health professional who discovers an alcoholic or an addict in a patient's nuclear or their extended family should expect to be reimbursed for the treatment, even if the identified alcoholic is miles away and not in treatment? Do we minimize the needs of the family members and, for financial reasons, refuse counseling and guidance, even while we know it can lead to early identification of chemical dependency as the primary problem? Training families and other people how to orchestrate an intervention is going to bring reluctant addicts through the denial process and treatment long before they otherwise would be. Early treatment results in cost reduction, but insurance again remains the problem. The 1980s, we also saw a surge in the movement to call attention to the special needs of the children of alcoholics, both the young and the adult, because they're described as having unique problems, distinct from those even in children of other multi-problem families. Organizations were formed on both state and local levels to kind of address these needs. A state, there was a stated goal of at least one coalition for adult children of alcoholics was insurance coverage for their treatment. And this led to more struggles between insurance and the providers. We still don't know how much of this movement is fad and how much of the wave of the future is going to be, much less what the real treatment needs may be. It's not too early, however, to foresee increased struggles over the limited treatment dollar, as those in need of chemical dependency treatment are defined in an ever widening circle. Other disciplines come forth to describe what that treatment should be and where it should be given. Extension of the term addiction to include all sorts of dependencies may be an expensive ploy which could backfire. Nicotine, for example, it's a highly addictive drug, but food and sex are needs of nature that require control by all people. Our profession needs to think twice about encouraging lawyers to use the term sex addiction or food addiction as defenses in criminal suits. Treatment facilities have not always waited for answers and kind of had to adjust their behavior to fiscal reality and opportunity. As a result, we now hear of more and more facilities that offer residential family treatment. At one treatment center, each family member was given a physical, a psychiatric diagnosis that was chosen from the DSM 3, and a full medical record. Rates were the same as for the addicted family member. And this treatment was described not with apology, but kind of with an air of triumph. The payment system was outflanked, seemingly to everyone's profit. And then as the 90s approached, the notion of codependency broadened to include almost anyone who came from a dysfunctional family, whether or not alcohol or drugs even played a significant role in that dysfunction. Now, yet another group was invented into often very costly residential treatment, again, under a psychiatric diagnosis. Even if one does not object to this dishonesty per se, and they feel that civil disobedience or a defiance of policy and procedure is justified if one is doing good for the people, at least two long-term consequences followed. One was the tremendous cost of family treatment. It provoked resentment and backlash, so that other more appropriate treatment settings also risked being left uninsured. Most of the charts, the lab tests, the physical exams, and other forms of overtreatment are just not required. A hospital room is not needed for a fully ambulatory person when a local motel offers rooms for much less than the hospital rates. Less costly arrangements can be made even though the expenses will usually be only partially reimbursable. Another hazard is that family members are given a psychiatric diagnosis, and whether or not the diagnosis is accurate, medical records are created for people, many of whom are still young and they're unaware of the implications. And the day will certainly come when a person's medical record can be examined as a part of a routine screening process or a security check. It may include a psychiatric hospitalization dating from childhood or early adolescence, and perhaps even other from various treatment facilities if treatment was required more than once. How convincingly can people then explain that this was to ensure payment from an insurance company and that while frightened and upset, they really had not been mentally ill at all? There are still wide variations among states in the amount of funds that are available for chemical dependency treatment. Some of these inflexible patterns force us to, suggest that we know, the treatment that we know is not well suited for the patient's needs. Ideally, we want to have an entire spectrum of services from which we can choose, and that range might include outpatient care, social setting detoxification, halfway and quarter-way houses, partial hospitalization, which we call PHP, and short and long-term residential care in freestanding or hospital-based settings. In many communities, only a few of these services exist. In others, only certain groups of insured people have the financial access to them. Um, so, if a patient clearly requires removal from the home and a controlled, drug free environment in which to recover, a hospital based program may be the only alternative. While these hospital based programs often can and do give superb care, there is no question that they are expensive and in many cases it's necessary only because the less expensive alternatives are just not available. And counselors who really do want to individualize treatment and select the appropriate level of care are caught between giving much too much or much too little. Because lives are at stake here, and because people are more valuable than dollars, there may be little choice other than to opt for the overtreatment. But not surprisingly, the 1980s also saw a rapid increase in HMO, preferred provider organizations, and managed care. Some of this resulted from the overall increase in healthcare costs. Some was a response to overcharging, greed, and the questionable business practices of hospitals and healthcare workers, and many of the chemical dependency treatment providers themselves. Um, Probably the most bothersome issues in our field today is that's posed by the managed care, called by some quote unquote managed cost or mismanaged care. Rather than blaming the HMOs, the insurance business, the greed of the treatment centers and the private practitioners, or even government bureaucracies, all of whom share that responsibility for the mess that we're in, the most constructive approach seems to lie in cooperation between all those warring factions. Taxpayers, premium payers, and the insurers certainly all do have a right to be concerned about the cost containment. The profession has a legitimate concern about quality control and professional standards, and the government at all levels has some responsibility for both. How to balance these sometimes competing interests is really a formidable task. Turfdom and interprofessional animosity really don't make it any easier. The National Council on Alcoholism and Drug Dependence, NCADD, and other field organizations have made a very good point that clinical decisions are now being made by telephone, often by a clerk in an insurance company or a government office who may have had little or no clinical training or experience or knowledge of alcoholism and other addictions, and all of this without ever seeing the patient. These decisions need not necessarily be made by a physician. In fact, in spite of the gratifying growth of the American Society of Addiction Medicine, or ASAM, members of the medical profession, including deans of medical schools, admit that the average physician today still has less understanding of these problems and the patient's needs than a well qualified professional addiction counselor or nurse specialist. Decisions should, however, be made by someone knowledgeable about addiction medicine, someone whose performance is not measured primarily by the amount of treatment refused or money saved. And lastly, no institution that really wants to be well regarded and accepted can do without paying attention to their public relations. Referrals tend to come from friends, not strangers. Networks and linkages need care and attention if patients are to flow smoothly between the people who are responsible for their care. People and organizations often send Christmas cards. The card may be replaced the following year by a calendar. In the calendar, may in turn be replaced by a modest gift like a memo pad holder or an inexpensive pen. At times, the gift may become progressively more lavish. One EAP counselor who referred many patients to a particular facility received increasingly substantial gifts from them until she received a very large cheese wheel, complete with several sausages and tins of gourmet delicacies. Her statement at that time was, "I'm beginning to feel bribed." Bribery has indeed entered the field. Empty beds are expensive. Expenses stay fairly static, whether or not occupancy is good, but when only a few patients are in residence, there's not much income. And with a few quick calculations, the amount of money at stake becomes apparent. At $300 a day, keeping a single inpatient bed full all year would bring $109,500. For that kind of return, it makes sense to recruit patients aggressively. And some people with the power to send others to treatment may be well paid and unlikely to be tempted by invitation to make deals. But many others are not. And while counselors working in employee assistance programs tend to earn respectable salaries, those in the not for profit sectors, they're frequently underpaid, not only in dollars, but in appreciation and recognition for the work that they do. Many would love to do this work, but they feel that they just simply can't afford it. It's not surprising then that alliances are formed that don't always work to the benefit of the patient. Outright payment for referrals does occur, even though it's not supposed to, and there are many subtle variations. One EAP counselor let it be known that he was available to lecture to patients in a New York City treatment facility for a fee. He added that he would find it convenient to lecture when he was escorting a patient to the facility for admission. Another described how he routinely drives his referrals to a New England facility where he's handsomely reimbursed for travel expenses, warmly received, and well fed. The practice of trading favors, however, is fading. Facilities have their own marketing people and field representatives whose task it is to create a demand for service and to ensure that the patients choose to have their treatment with them. Television, radio, and print invite the patient to be evaluated and intimate that most insurance policies will cover the treatment. And there's nothing wrong with this if what is offered is honestly described and if the outcome of the initial evaluation has not been predetermined in such a way that the client with the insurance inevitably ends up in residential treatment irrespective of their need. The field representatives of treatment providers are expected to fill the beds and keep up the census. And if they do this successfully, they are well paid. But if they fail, they're often out of work. They may try to make contact with those who can refer large numbers of patients. They may also try to win the reference loyalty to both the facility they represent and to themselves. And since many field representatives will change employers and gain substantial salary increases through their ability to make or take their contacts and followings with them, this can be done simply on just the basis of friendship. Sometimes the referral source believed the counselor's new facility is better than the former one and that the job change involved a desire to represent the place that does the best for the patient. And sometimes it is, and other times the issues are financial. Gifts and favors have sometimes been replaced by a bounty system in which money changes hands for every client that's successfully referred into treatment on a per capita basis, which is also against our ethical codes now. But an extreme case in a Western city involved an EAP counselor who was offered payment for each patient delivered, as well as a full 2-week vacation in the tropics if enough of his firm's employees could be persuaded to have their treatment in that hospital. More recently, a northern treatment facility arranged with two union based counselors in the South to have all their referrals flown there for treatment. In a society that's casual about accepting kickbacks and a variety of white collar crimes, there's no reason to expect the addiction field to escape such problems. Everybody's doing it. That is, however, simply untrue. Relatively few people are doing it, and those who do are increasingly liable to be discovered. We have the integrity and the ability to keep dishonesty to a minimum, and we must learn to do so, or our patients are going to be hurt.